Welcome to KJR SummaryCast. SummaryCast provides audio summaries of KJR articles created using an in-house AI tool with editorial or author review. For full details, please refer to the original article. Welcome to SummaryCast.
Today we're looking at a review article from the Korean Journal of Radiology, Volume 27, Issue 5, published in May 2026. It's titled Ultrasonographic Evaluation of Pediatric Thyroid Nodules, Adult Risk Stratification Systems, 2021 KTIRADS Revision and Future Refinements.
Right. So the central theme here seems to be that thyroid nodules in children are not just smaller versions of adult nodules.
Not at all. The author lays out a very clear case that pediatric thyroid cancer is its own distinct entity. While it's much rarer than in adults, about 13 to 15 times less common according to SEER data cited in the paper, the stakes are different when a nodule does appear.
Different how? What are the numbers?
Well, the probability of a nodule being malignant is significantly higher in children. The paper puts the range at 22 to 26% for kids, compared to just 5 to 10% for adults.
So lower overall incidence, but a much higher pre-test probability for any given nodule.
Exactly. And the clinical presentation is often more aggressive. Regional lymph node metastases are found in approximately 60 to 80% of pediatric thyroid cancers at diagnosis.
And in adults?
That number is closer to 20% to 50%, so it's a substantial difference. Distant metastases are also more frequent in the pediatric population.
That sounds like a much more worrying clinical picture. But the paper makes a point about a paradox here.
It does. Despite this aggressive initial presentation, the long-term prognosis for children is excellent. The all-stage mortality rate is less than 1%, which is even lower than the 1 to 2% seen in adults.
So it presents aggressively but responds well to treatment. A very different disease profile.
Precisely. And that raises the core question of the review. If the disease is so different, should the diagnostic rulebooks be the same? Is it really appropriate to apply ultrasound risk stratification systems developed for adults directly to children?
I'm guessing the answer is no. How well do those adult systems actually perform in kids?
You know, that's where the data gets pretty concerning. The paper references a 2021 meta-analysis that looked at the diagnostic accuracy of the American College of Radiology's TIRADS, or ACR TIRADS, when used on children.
And?
The pooled missed malignancy rate was 21.7%, and the unnecessary biopsy rate was 62.7%.
Wait, say that again? Over 1/5 of malignancies missed, and nearly 2/3 of biopsies were unnecessary? Whoa.
It's a tough balance. The paper also discusses a study by Kim and colleagues that directly compared 5 major adult-based systems, including the ACR TIRADS, the American Thyroid Association, or ATA guidelines, and the 2016 version of the Korean TIRADS.
How did they stack up against each other?
It was a mixed bag. The ACR TIRADS had the highest specificity, around 78%. This means it was the best at correctly identifying benign nodules and avoiding unnecessary biopsies.
What's the mechanism for that? Why was it more specific?
The review suggests it's likely due to its higher biopsy size cutoffs for moderately and mildly suspicious nodules. For instance, it recommends biopsy from mildly suspicious nodules only when they're 2.5 centimeters or larger, whereas other systems might use a 1.5 centimeter cutoff.
Okay, so bigger size thresholds for lower risk nodules help reduce unnecessary procedures. Fair. But what about the other end of the spectrum, the high suspicion nodules?
That's the other side of the problem. The risk of malignancy in that highest suspicion category is dramatically higher in children. The study found it ranged from 85% to 94% across the different systems.
And in adults, that risk is what, more like 30 to 60%?
Exactly. So applying the standard adult biopsy cutoff of 1 centimeter for these very high-risk nodules in children might be leaving cancers on the table, especially smaller ones.
Right, so the adult systems are potentially biopsying too many low-risk nodules and too few high-risk ones. It sounds like what's needed is a kind of two-track approach.
You nailed it, and that is precisely the logic that drove the 2021 revision of the Korean Thyroid Imaging Reporting and Data System, or KTIRADS,
which is a major focus of this review.
Okay, let's get into that. What did the 2021 K-TIRADS change specifically for the pediatric population?
It implemented that exact two-track strategy we just discussed. The most critical changes were to the biopsy size cutoff criteria.
Let me guess. They lowered the cutoff for high suspicion nodules?
They did. For KJR 5, the high suspicion category, the biopsy size cutoff for children was reduced from 1.0 centimeters down to 0.5 centimeters.
A pretty aggressive change. And for the lower risk categories?
They went in the opposite direction. For intermediate suspicion nodules, KJR 4, the cutoff was actually increased from 1.0 centimeters to 1.5 centimeters, provided the patient doesn't have other clinical risk factors.
And for low suspicion nodules?
That cutoff was also increased from 1.5 centimeters to 2.0 centimeters.
Okay, so it's a more nuanced approach. Lower the bar for the most dangerous-looking nodules, but raise it for the less concerning ones to avoid over-investigation. Did it work? What did this do to the diagnostic performance?
The paper cites data directly comparing the 2016 and 2021 K-TIRADS guidelines. The results were quite striking. Sensitivity saw a significant jump from 81.2% with the old guidelines to 90.3% with the new ones.
A big improvement in catching malignancies. What happened to specificity? Usually it takes a hit when you boost sensitivity.
It didn't, and that's the neat part. Because the system also raised the biopsy cutoffs for lower-risk nodules, specificity actually improved as well, going from 37% to 47.9%.
So both metrics got better. That's not a trade-off. That's just a better system. Overall accuracy must have improved then.
It did, from 58.4% to 68.9%. The review includes a radar chart, Figure 1, that visualizes this really well. The area for the 2021 K-TIRADS is just visibly larger and better across sensitivity, specificity, accuracy, and even the unnecessary biopsy rate.
It's compelling. Does the review touch on attempts to modify other systems like the ACR TIRADS in a similar way?
It does. The ACR TIRADS is the most extensively studied, and several simulation studies have explored modifications. The ideas are quite similar. For instance, lowering the biopsy threshold for the highest risk category, TR5, to 0.5 centimeters, or even biopsying any TR5 nodule regardless of size.
And the outcome is predictable, I assume. Higher sensitivity, lower specificity.
That's right. You find more cancers, but you also end up doing more unnecessary biopsies. It highlights that sensitivity-specificity trade-off.
Got it. What about adapting the criteria based on clinical risk factors? The K-TIRADS revision mentioned that for intermediate suspicion nodules.
Yes, and that seems to be a promising avenue. The paper describes a simulation study by Lee and colleagues that took this idea further. They tested what would happen if you lowered the biopsy cutoff for intermediate suspicion nodules down to 0.5 centimeters, specifically in children with known risk factors.
And what are we talking about for risk factors, like family history?
Exactly. A family history of thyroid cancer, previous radiation therapy, or known hereditary tumor syndromes. In that simulation, applying this risk-adapted approach improved overall accuracy for both K-TIRADS and ACR TIRADS.
So a more personalized approach to risk stratification seems to be effective.
It certainly appears to be. This leads the author to zoom out and discuss the bigger picture and future challenges, moving beyond just tweaking size cutoffs.
Where does the discussion go from there? What's the next frontier?
Well, the first major consideration is the ever-present issue of overdiagnosis.
Right. A huge topic in adult thyroid cancer. Does it apply in the pediatric setting as well?
The author argues it's a critical consideration, given the excellent prognosis and the potential lifelong consequences of thyroidectomy in a growing child, effects on skeletal maturation, cognitive development. There's a very high bar for intervention.
Makes sense. You don't want to subject a child to that unless it's absolutely necessary.
Precisely. The Fukushima Health Management Survey is mentioned as a case study. After the nuclear accident, widespread screening of children revealed a surprisingly high prevalence of thyroid cancer, but most were small and remained stable on follow-up.
So a reservoir of indolent disease exists even in children. Finding more cancer isn't the only goal.
Right. The goal is finding the clinically significant cancers that need treatment. Another layer of complexity discussed is the heterogeneity within the pediatric population itself.
You mean a 4-year-old with a nodule is not the same as a 16-year-old?
Exactly. The current pediatric cutoff is typically 18 years, but several studies have shown that prepubertal children often present with more aggressive disease features than adolescents, larger tumors, more frequent metastases.
Quantify that. How big is the difference?
It's significant. One study cited by Lazar et al. Found that prepubertal patients had a 100% rate of lymph node metastasis compared to 47% in adolescents. Distant metastasis was 70% versus 23.5%.
Wow, that's a dramatic difference. That suggests that age itself should be a major risk stratification factor.
It does, and this may be genetically driven. The paper points out that the molecular profiles are distinct. In adults, the BRAF V600E mutation is very common. In pediatric cancer, it's less frequent, especially in younger children.
And what's more common in the younger kids?
Gene fusions, particularly those involving RET or NTRK. These fusions are often associated with more invasive tumors and higher rates of metastasis, which could help explain the more aggressive presentation in the youngest patients.
That has clear implications for therapy, too, with targeted inhibitors for those fusions.
Precisely. The author suggests a future direction where ultrasound-based risk stratification doesn't just decide biopsy or not, but also helps triage for molecular testing. The results could then be integrated into a more comprehensive post-diagnostic risk assessment.
Okay, which brings us to another future refinement: artificial intelligence. Ultrasound is notoriously operator-dependent. Can AI help standardize things?
That's the hope. The review discusses a pilot study by Ha and colleagues that's particularly interesting. They took a deep learning model that was trained on adult thyroid ultrasound data and applied it to 156 pediatric thyroid nodules.
A model trained on adults applied to kids. How did that work out?
Surprisingly well. The AI model showed robust performance. Its area under the curve, or AUC, for differentiating malignant from benign nodules was around 0.92.
And how does that compare to radiologists using the standard systems?
It was significantly better. The AUC for radiologists using ACR TIRADs or K TIRADs was about 0.83. The AI was particularly strong on specificity. It was much better at avoiding false positives compared to the K TIRAD system, 79.8% versus 49.5%.
Okay, but I sense there is a catch?
Spot on. There are important caveats. It was a retrospective study relying on previously acquired images from a cohort where the final diagnosis was already known. This introduces selection bias.
And the operator dependency problem isn't solved.
Not at all. An AI can only interpret the images it's given. The skill of the sonographer in acquiring high-quality images remains paramount. The paper frames AI as a promising tool for enhancing objectivity, but one that needs substantial and robust evidence before it's ready for prime time.
Got it. So beyond system refinements and new tech for the usual cases, what does the paper have to say about diagnostic challenges specific to pediatric patients?
The review highlights two really important ones for the pediatric population. The first is a specific subtype of cancer, the diffuse sclerosing subtype of papillary thyroid carcinoma, or PTC.
I know it's rare, but more frequent in children, right?
Yes, it makes up about 3% of pediatric PTCs, compared to less than 1% in adults. The diagnostic challenge is that it often doesn't present as a discrete nodule.
What does it look like on ultrasound?
It typically appears as diffuse thyroid enlargement with numerous scattered punctate echogenic foci. It can easily be misinterpreted as a diffuse parenchymal disease like thyroiditis.
So how does the new K TIRADs handle that?
This is a key refinement in the 2021 version. It specifically classifies this pattern, extensive parenchymal punctate echogenic foci without a discrete nodule, as K TIRADs 4, or intermediate suspicion.
So it gives a clear directive to consider it suspicious even without a classic nodule. That's a very practical addition.
It is. The other major diagnostic challenge is a benign entity, intrathyroidal ectopic thymus.
A common mimicker in young children.
Exactly. It can appear as a hypoechoic solid nodule,
often with internal punctate or linear echogenic foci, that can be mistaken for microcalcifications. The key, as the paper points out, is the clinical context.
Meaning the age of the patient.
Right. Intrathyroidal ectopic thymus is typically found in very young children, often under 4 years old, an age group where thyroid cancer is exceedingly rare. The paper suggests that in these cases, a differential diagnosis of ectopic thymus is warranted, and follow-up without biopsy might be the most appropriate course of action.
Okay, so a key takeaway is that for certain patterns and certain age groups, clinical context should override a purely feature-based risk score.
You could say that. It's about integrating all the information. Future guidelines, the author suggests, may need to formalize this and provide clearer pathways for handling these known mimickers.
So let's land this. What are the bottom line conclusions from this review?
At a high level, the message is clear. Pediatric thyroid nodules demand a pediatric-specific approach. Adult-based risk stratification systems are a poor fit because the underlying disease biology and risk calculus are fundamentally different.
And the 2021 K-TIRADS represents a significant step forward with its 2-track biopsy cutoff strategy.
It does. It has demonstrably improved diagnostic accuracy by being more aggressive with high suspicion nodules while being more conservative with lower suspicion ones. The author posits it's a very appropriate framework for current management.
But significant challenges remain. There's age-related heterogeneity, even within the pediatric group, diagnostic mimickers to contend with, and the need to validate and integrate emerging technologies.
Exactly. The future refinements discussed in the paper all point toward a more stratified and integrated approach, one that considers patient age, molecular profiles, and AI-assisted analysis to move beyond a one-size-fits-all system.
A comprehensive and forward-looking review. That's all the time we have for today.
Join us next time on SummaryCast.